Should we get started?
Sure, we can do that. Let me just stop sharing my screen. All right. Well,
Welcome.
hello, everyone.
Yeah, go ahead, Carissa.
Oh, it's okay. You can go ahead.
Welcome. Good to see everybody. Happy frozen Thursday, I shall say. It's a little cold out. We'll do introductions and then we'll hear from Emma and then we'll hear from Bridget. So it should be a good day. Good echo clinic. So I'll start out. My name is Piper Meyer Kalos and I am an IRT clinician at SLP, Navigate, and also one of the PIs on EpiNet. And I'll turn it over to Carissa.
I just realized my video wasn't on. Good morning, guys. Hi. So I'm Carissa. I work as a researcher, coordinator, project manager with Piper, and have done so now for the last 5-ish years in the Department of Psychiatry. And then I also do a small amount of clinical work at the St. Louis Park Clinic. And I'm super excited for today's topic, also because the speaker is somebody that I have known since before my days of doing this, like when I still worked in the service industry. So anyway, I will pass it to Orly.
Good morning, comrades. I'm Orly Haven. I am the family clinician at the Navigate program in St. Louis Park, Minnesota. And it's really dark in my attic office right now, but I'm enjoying that. You know, we just passed Imbolc, the halfway point between winter and spring. So we're actually closer to spring than winter now. Just saying. And I will pass it to Max.
Good morning. My name is Max. I'm a family clinician at the Strengths program of the Riverside location in Minneapolis, and I will pass it to Nancy.
Good morning, everybody. My name is Nancy. I'm the family peer for the Navigate teams out of St. Louis Park and also Strengths out of Riverside and the Hope program through Hennepin. And I also work at NAMI, Minnesota, and I will popcorn to Bridget.
Good morning, I'm Bridget. I'm a clinical social worker and I conduct diagnostic assessments out of SLP. And I also co-lead the C peer support group. And I will pass it to Zemzem.
Good morning. My name is Simsim. I'm the social work intern from St. Mary's University, and I will be interning at the St. Louis Park and working with Melissa.
How about Elizabeth?
Oh, sorry.
Yeah, go ahead, pass it. We can pass it to Elizabeth, is who I was looking at.
Okay. I don't remember who went, but if you do, could you pass it to them? Thank you.
I can go. I'm Elizabeth Habish, IRT at the Hope program in Minneapolis. I will pass it to and welcome back Laurel to the FEP world.
Hi, good morning. I'm Laurel Bieshki. I used to be with the Hope program, IRT. I'm now with the new program Compass over at Radius Health in St. Paul and the program director and family clinician. And I will pass it over to Danny.
It's a good chance Danny might be still driving in today.
Sorry, I'm here.
Yeah.
I just couldn't find my mute button. I'm like about to walk in.
There you go.
So I'm Danny. I'm the C specialist at the Hope program, and I will pass it to Jessica.
Hey, I'm Jessica, or I also go by Jess. I'm a grad student in the clinical psychology department at the U first year, and I am helping my Piper on an IRT manual and just here to kind of learn and absorb. So thanks for having me again. And I will popcorn to, is it Andrea or Andrea? Have you gone?
Yep, it's Andrea. Thank you. Yeah, I got a little late. So I got here a little late, so I wasn't sure. But thank you, Jess. I'm Andrea Botzett. I am a marriage family therapist at the Riverside office in Minneapolis. And I also work in private practice clinically. So I will popcorn to Krista. Have you gone yet? Or okay.
Hi, no, I was also a little bit late. I'm Krista Reeder. I'm a clinical social worker and an IRT clinician over at the St. Louis Park Navigate program. And I'm not sure, has anybody?
I think Mauricia hasn't gone yet.
Yeah, why don't you go?
Hi, Mauricia. I'm over at the St. Louis Park Clinic with Krista, also doing IRT. I'm in my final semester of my master's program over at St. Kate's.
And I think Stephanie is left.
Hi, I'm Stephanie. I am the C specialist with Navigate. Is there anybody else left that needs to introduce himself?
I think the last one is Emma, who will just let her start. Introduce yourself and feel free to start. We've got Kayla joining, but we'll wait till there she is. Kayla, do you want to do a quick introduction before we go to our speaker?
Oh, you're muted.
Of course I am. So my computer decided to update right when the meeting got started, which is perfect timing. So I am Kayla. I am the program supervisor for the child and family team up at the Human Development Center in Duluth. And I am also the team lead and the FEP IRT for the FEP team up here. Kinsley, did you want to say hi before the meeting starts? And I have one other person that wants to say hi. I have a guest with me today because we have treatment this afternoon.
Hi.
Hi. Oh, okay.
I think, Emma, it's all yours.
All right. Hi, guys. Thank you for having me. Carissa, thank you for inviting me. As Carissa said, we go way back before I refer it to as my other life before I got sober, even when I knew her. So I am a certified peer recovery specialist. I live in Duluth actually as well, and have been working at Cara Carlton in Carlton, Minnesota, just outside Cloquet, up until about a month ago. I'm currently actually getting ready to have a baby, so focus is shifting onto that. But yeah, let me see if I can figure out how to get my thing open.
Do you see the menu at the bottom where it says?
Yeah, the screen share.
Yeah.
Oh my goodness.
I can pull them up on my end too if it's trouble.
Okay. Let's try. It's pulling up like security and privacy and trying to.
Oh, okay.
Not granting me access to my own thing.
All right. Well, let's see if I can do it faster for you. I think you just sent me a PDF. We can do it that way if that's easier.
Yeah, I guess if you can.
Yeah. And I'll just have to scroll through it.
Okay.
So yeah, this will work, right? And I can just scroll.
Yeah, this will work.
Okay.
Yeah, just scroll. You're good.
Yeah.
Awesome.
Okay. Cool. Thank you. Yeah, so today I'm just going to talk a little bit about the role in general and my role as a peer support in recovery from substance use and mental health disorders. So starting with a little background information. I have 6 years of recovery from a substance use disorder. I've been certified as a peer recovery specialist since 2019. I completed my training through Fond du Lac Tribal and Community College in Cloquet, where I'm actually currently still a student, working on getting licensed as an LADC and
I would also like to be duly licensed as a mental health professional at some point down the line. Yeah, like I said, I spent the last 4 years providing peer support at a co-occurring treatment facility, which is the CARE program. I'm not sure if anyone is familiar with that. So CARE, if you want to scroll down, Carissa, is Community Addiction Recovery Enterprise. It's a branch of DHS MSATs, the Minnesota Department of Human Services Mental Health and Substance Abuse Treatment System, which is why we have acronyms. They operate, let's see, there's 5 facilities across the state of Minnesota in Anoka, Carlton, Fergus Falls, St. Peter, and Wilmer. All the care sites are locked facilities, so they're secure facilities. And we only take clients who are on a civil commitment, either civilly committed as chemically dependent, mentally ill, or both. And the care site at Carlton that I worked at was actually the only gender specific treatment program. It was an all-female, or is an all-female facility. So we only take female clients, as well as only having female staff members, which was pretty cool, I thought. Let's see, there's 16 beds. We haven't been able to be at full census for quite some time now, actually, just due to like staffing shortages. Pregnant women and IV drug users are given priority admission. It's a high intensity program, so the clients are expected to attend 30 hours of group programming a week, in addition to all their individual meetings with the CD counselors and the mental health professionals and whatnot. And they typically spend 45 to 90 days there before they transition down to their next level of treatment, which is usually a medium intensity or like an IOP with lodging or something like that. When I started, they just had the one peer specialist position, and then they eventually added a second one. So they had 2 of us working there, which was really beneficial. Yeah, so my role there, I would facilitate peer recovery support groups. So the traditional ones, we would do AA and NA. And then I really like to expose and kind of provide some education on alternative recovery groups, such as like Women for Sobriety, Smart Recovery, Dharma Recovery, and just make them mostly like spread awareness, because a lot of clients are like not even aware that these programs exist. And part of, a huge part of recovery is just finding what works for you individually. And, people aren't cookie cutters. So it's like AA and NA are great programs, but they're not going to work for everyone. So it's just about, finding what works for you. Excuse me. So yeah, doing groups, also a lot of one-to-one time. So just kind of providing that one-to-one guidance and support in kind of whatever they were dealing with. Also sitting in on the other groups. So the groups facilitated by the LADCs and the MHP, I would sit in and just kind of share my perspective so that they could hear the perspective of someone who had been through what they'd been through and was now actively living in recovery, and, challenges I had and what had worked for me and whatnot. Yeah.
If I scroll too fast, just stop me, okay, Emma?
Okay, no, you're doing good so far.
All right.
So some of the benefits, I believe peer support is really an integral part of successful recovery for clients. Just having that validation of their experiences, providing empathy, giving them hope that recovery is possible, and you know, people do it all the time. And I'd be like, I did it, you know, you can do it. A lot of the times I found clients would be, they'd be more comfortable sharing with me or our other peer specialists just because they were like, I mean, they would tell me that. They'd be like, I feel, you know, you're not going to judge me because you've been through the same thing. So yeah, definitely like a less fear of judgment, and more willingness to, you know, follow through with advice and treatment recommendations. Yeah, just like making them feel heard and seen as people. A lot of the times they, you know, felt like they were just a number in the system, especially clients who had been institutionalized from a young age and for most of their life. So, you know, making them feel seen as a person. Yeah, and really just being able to like build that foundation of trust and rapport that I think is necessary before you can kind of go on to any other deeper level. Yeah, and it works really well, just like balancing, adding the peer support to the other disciplines and just kind of balancing it out. So you have all those different perspectives kind of working together for the client's treatment. Yeah, and just working as an advocate for them too, as well. Like a lot of I would sit in on our like weekly clinical meetings, and the clients were not allowed to participate in those, and it was kind of nice for them to have, I feel like, have someone there to sort of provide a voice for them in that context. You can go to the next one. So some challenges. I think one of the biggest ones was kind of expected to fill dual roles where they were like, you know, you're considered a peer and an equal, but you're also part of the treatment team and a provider. So it was kind of weird. Like I said, it was a little difficult navigating that. Like, what do you want me to be? Do you want me to be a peer with the client, or do you want me to be, you know, a part of the, you know, clinical team, and sort of like riding that fine line? That could be difficult. Working with clients outside our scope of training was hard as well. I mean, I have my experiences obviously, and then, you know, 40 hours of training, but we are working with clients who are, you know, civilly committed as mentally ill and chemically dependent, like with some of them were pretty, you know, really, actually most of them with really significant trauma, some with like cognitive and neurological deficits, like a lot of TBI, FAS, pretty significant like behavioral issues. So that was kind of a bit of a challenge to sort of be thrown into that and expected to really just know how to work with clients who are at that, you know, extreme of a level. Let's see, what else? Yeah, just kind of a lack of support too. And the, you know, peer support is a relatively new field. So people not having quite as well a good of understanding of like what it is and what it entails. When I started in the role, it was empty before I filled it. So it was basically like, we're going to give you this, and I didn't have any like training or guiding from someone who had done it before me. They're just like, here you go, figure it out. Which, you know, in some ways was actually beneficial, because I could kind of in ways make the role like what I wanted it to be. But in the beginning it was a little rough, because I was just like, I don't really know what I'm supposed to be doing. I don't have anyone to go to talk to this about. Like my supervisor was the LADC supervisor. So, you know, an awesome lady, but not familiar with like what a peer support specialist does, or had any experience working in that role herself. Yeah. What else? Yeah, you can go to the next one. So yeah, just some, suggestions for kind of moving forward based on what I experienced. Having access to others working in peer support roles, I think, is a really big thing. It was very helpful for me when they added that second position. So there were two of us, and we were able to, have that, consult with each other and have that support. So it would have been nice to be able to have access to more of that, because I know that it's becoming a much, a wider role that a lot of places are offering. And then, like I said, supervision is really important. Having someone who takes a more proactive and kind of teaching role as opposed to a passive role can be really helpful, because I did have multiple different supervisors over the years. And then someone who is more familiar with that role or has even done it themselves would be ideal, I think. Yeah, and then, like I said, just continuing education as well. And yeah, that's all I have. Thank you guys. If anyone has any questions about anything, I'm happy to answer them.
I have a feeling we will have lots of questions, so.
Thank you. This was perfect. This was excellent. I think this is exactly what we were looking for. So I appreciate you putting this together. I'm just going to open it up to questions that folks have.
Good morning.
ahead.
I have a question. I'm Orly. I'm wondering if you could say a little bit more about navigating that line of being a peer and being a clinician. I can just imagine how different contexts and scenarios and maybe personalities and perspectives of other people could come into play. So I guess I'm wondering, could you say a little bit more about what you found particularly helpful and important coming from your clinician colleagues, if that makes sense?
Yeah.
Thanks.
And part of it is that, so, as working as a clinician, there's a lot of strict rules about, disclosing personal information. That's a huge no, you don't do that. But then part of working as a peer specialist, it's the description of the role is that you are sharing your lived experiences. So that was kind of that big, divide of I'm, maintaining professional boundaries, but also being told that I need to share about my personal life. And, I guess what was pointed out to me early on or told to me was just, before I share anything, just ask myself, is this beneficial for the client to hear that? And then kind of pass everything through that filter. And that was helpful. But like I said, yeah, it is a little difficult to try to fill both of those roles simultaneously. And my only experience working in peer support is at Care Carleton, and it's a pretty unique setting in the fact that it is, it's secure residential facility. So the clients they're locked in, they can't go anywhere. So we're basically just on the unit 24/7. So I guess, yeah, I forgot to mention that during the presentation, but just that's been my experience. But I think it is, from what I know, peer support, it looks different depending on what facility you're at. And I know a lot of other places that are more open work a lot more within the community and bringing people into the community, and the peer support kind of comes in that way.
Andrea, I think you had a question. Oh, you're still muted.
Sorry, there we go. I did, but actually it was very much in line with what Orly had said, and Emma responded beautifully, so I got it. Thank you, though.
Okay, well then I have a question, Emma, because I think that it would be helpful from your perspective. I mean, you said that the job was kind of open when you got there. They hadn't done this very much. And you kind of got to when the new person came on, you kind of got to generate some more things. What are some ideas that you might give us as clinicians where you as a peer support specialist can be really helpful? In what ways do you like support or like even, you know, that empathy or being along with someone? Are there ideas that you have that we as clinicians might think about, like this is where a peer could be really helpful, or ideas of like, here's some things that a peer might want to think about that kind of fit within your scope?
Mm-hmm. Yeah. I mean, like I said, facilitating the peer recovery groups, I think was a really, really beneficial thing that we did. And it kind of provided like just a safe place for only peers. You know, there was no other clinicians or staff or anyone there. So it was, you know, kind of imitating the atmosphere of a recovery meeting, you know, where it was just like, we're all here, we're all in this together. I think that was really beneficial to have incorporated into our program, just giving the clients that space to really be able to open up, you know, not that they didn't share in other groups, but we found it was a little different, like, you know, they would feel more comfortable kind of sharing in that environment where they're like, everyone here knows what I've been through and has experienced what I've been through. So I think that is really important. And I don't know, just being there. I mean, I did a lot of like filling in where they needed me as well, which involved like, I would take clients on transports, sit in on them when they were doing like a video assessment or an interview. And I think it was just really beneficial just to have someone there, especially someone who, you know, they can relate to and they know they feel comfortable with, and just having them there, like helping them navigate the treatment process and the civil commitment process and whatnot. Yeah.
Very helpful. Yeah, I appreciate that. I'm going to ask one more question. And this is coming from kind of a supervisor standpoint, because one of the things I feel like we are still learning too, and the newness of some of this and trying to get more people like you integrated in our teams is how can we best support you? So that's my question. When you're coming in, what is it that you're looking for from a supervisor, right? It's that navigating what's my scope, what's, you know, inside or outside my scope. But also, as you said, you worked with a really tough population, a population that was struggling a lot with different kinds of things. When you go into a situation where you're working, what are the things that we as supervisors might think about that could help you feel more supported?
You know, like I said, I did have several different supervisors over the years. Having someone be in a more proactive kind of like teaching role was really helpful, because this is also, you know, was my first job working in the field. So I didn't have any other experience other than what I've been through myself, you know, which, so it was helpful, even if they didn't have a, you know, really solid understanding or background in peer support, but just coming in it from that perspective where I think, you know, a lot of people working in peer support haven't had any experience working in the field prior other than their own stuff. So you are kind of like, it's a new experience. And, you know, we do have like the training and stuff, but it's like, all right, 40 hours of training. Okay, here you go, you know, versus some of my coworkers who had been in school for like 8 years working on stuff like that. So as a supervisor, you know, it was helpful to have someone take on more of that kind of active like teaching role. in whatever way they could, obviously that's, I don't know, they're not a professor or anything, and that's like you're out not in a classroom, but just having, being able to, I don't know, like I said, kind of be more active and providing some education and some insight, as opposed to just like being more passive and just like, how's it going? Okay, bye, see ya, like, in and out, and instead be like, hey, let's talk about this today, and what are your thoughts on this, and how have you experienced this, and here's some advice and whatnot.
Is it helpful, do you feel like, to give ideas about ways that you can do things, or do you, I mean, because I'm curious, like, I feel like some of this is discovering where a peer can really fit and be the most beneficial. Do you like to are there things that they give you in training that you are going out and saying, this is typically what I do as a role, or is it helpful to help develop some of these coming in brand new?
I mean, I think it was, like I said, it was stressful when I started out, and just kind of having that blank slate and being like, okay, what am I supposed to be doing? And like I said, that wasn't, the training was more, kind of like ethics and stuff like that, not like, hey, here's like specific things you'll do. And also, like I said, it's different site to site. My understanding is a lot of at different facilities, peer support takes a more active role in like bringing clients into the community and involving them in that way, which, so like, with Care Carleton, it was very restrictive. We're in a locked facility. The clients have very limited access to anything really. So that was a unique position in that context. And I think that added to trying to incorporate like how peer support could fit in that environment. But my supervisors were all really great and really awesome with listening to me and our other peer specialists, and taking into account, what we had to say and what we were saying was working, and ideas that we had. Because it was just kind of like a little bit of just figuring it out as we go along and see what works and what doesn't work.
Yeah, for sure. I do have one more question. I love this because I get to pick your brain a little bit. This is a lot of fun for me. So not all of us right now have a peer support specialist on our teams, but we do have those weekly team meetings that you're kind of talking about that you got to be part of, right? You said you were part of the treatment team. You would be that role that you would feel like of the individual when they were talking about people. Is there anything that you would suggest that those of us who don't yet have a peer support specialist on our team take into consideration that voice? Is there something when they would talk about individuals that would come up where you would say, and don't forget about this, or let's keep this in mind? Is there anything that you would say that you would recommend for, again, to try to keep that perspective alive, or keep it fresh, or to the front of the line in some ways? Anything that you would say during those meetings that you regularly will speak up about?
I mean, I guess for me, a lot of it was, I did spend a lot more face-to-face time with clients than the counselors and some of the other practitioners, not because they didn't want to, but because they just didn't have time to. I had more time in my role, and they had more paperwork and deadlines and meetings, and having to be in offices with closed doors a lot. So it was really great that like me and the other peer, we could kind of provide, we just had our office door open all the time, and it was kind of like that open door, just come in, we can have a serious conversation, or just come hang out, or like, are you bored because there's nothing to do here? So like, I don't know, it was very, I think it was beneficial in that way to just have a lot of interaction with them, like much more interaction than a lot of the staff, and really just being able to get to talk to them more, just listen to them more, and then be able to bring that perspective to the meetings where, was like, hey, I like spend a lot of time with this person and this is what I'm hearing them say. And then my, also just like my subjective opinion too, is being like, hey, as a person in recovery myself, like maybe this and this and this is going on or whatever. So yeah, I don't know if that really answers your question.
That's okay. These are not, not easy questions, but I figured I'd see what you thought. So I appreciate you taking a stab at it and, giving us your perspective. Other questions that folks had?
I have sort of just a comment or a thought, which is like, in the work that Piper and I do with some of the things that we're developing and the research that we're doing, peer support comes up a lot. In the clinical work that we do, peer support comes up a lot. Like the people that we work with consistently tell us how, when they have access to peer support, how important that is for their journey, right? Whether it's substance use related, whether it's related to their psychosis, in some of the work that we're doing right now, developing the early mood program, are like the patients that we talk to on a regular basis to help us develop have consistently every time been like, sometimes peer support is actually like, you could throw all the rest of it out, right? Is the statement. Essentially, it's like, oh, without peer support, it's nothing. Like, we don't want to talk to clinicians. We would just rather talk to people that know what it's like. And I just, in listening to you talk, Emma, and in thinking about that, it's interesting that, you get 40 hours of training plus your lived experience, which is invaluable. And then you're just sort of sent out and you have more client contact time than any of us. The burden on you is often large, right? Because there's an expectation not only from the clinicians that you're sort of like the inside person and the person that can kind of do whatever they can't, but from the folks that you're working with, it's like, you're my therapist and you're my friend and you're my, advocate and you're everything. So I don't know that there's really a question in there. It's mostly just like, what a huge gift that you bring, that peer support people bring. And like, we really need to have more of it. We really need to integrate that more into the care that we provide. And I don't know what the answer is or what the solution is to making that happen, and making sure that you guys feel supported in that role, like really feel supported, like you're not being sort of sent out to sea without, being held up in what you're doing, or without, and like your opinion, your perspective really being valued by the clinical team seems important. And I wonder if you have had the experience of feeling like you aren't, like your perspective isn't valued by the clinical team in the way that it should be.
I mean, I think it actually was more of like the opposite, which is a good thing, or having a lot of starting out in this role, there's a lot of that imposter syndrome where I'm like, I relate more to the clients and I'm like, I'm used to being the one, being the client, and now I'm suddenly in this other role. And so there was a lot of that like kind of imposter syndrome of like, oh my God, I can't believe they're letting me do this. They don't like, and I worked with a really, really great team and they did, I know I talked a lot about like wanting more support, but I want to make it clear too that like I had a really great team, and they did a lot of good stuff. And I never felt like looked down upon or anything like that. Like I said, if anything, it was the opposite, where they were like, wanting me to expound more or something. And I'm like, really? You want to hear what I like? What? Like what? I don't know what I'm talking about. And they're like, no, you know more than you think was something I heard a lot of. Yeah. And then also something I thought of when you were talking to was because we would have a lot of clients who would be like, hey, I only want to talk to Emma, or I only want to talk to Jackie, who is our other peer specialist. And they were like, I don't, because they were like, you guys get it. Like, I only want to deal with you. I don't want to meet with my counselor anymore or anything like that. So, you know, that came up occasionally, and I would try to put it to them in the analogy of like, if they were a cancer patient or something, you know, like, you know, hey, what if you're diagnosed with cancer? Like, yeah, it would be helpful to like talk to someone else who had cancer, but also you would want to go to a doctor who specializes in cancer. And so kind of trying to like emphasize the importance of every role, like that peer support is really important, but like each role is important, and combined together is, you know, best for them. So
That's a really good analogy. I might steal that.
yeah.
I actually have a question that's pretty adjacent, Emma, to what you just said. And first of all, I just want to say, like, thank you so much for the work you do. One of my siblings works as a peer, and I didn't realize until I talked to them about some of their experiences. Like, I'm so struck by how peers help kind of restore more like agency and power to like a client-patient relationship, and just like the equity and the advocacy and like all the good big words that you guys bring to the team. And I'm sure it takes a toll too. So just like, thank you so much for your work. And my related question was, I'm curious how your role as a peer has played out in situations where, you know, obviously you're working with civilly committed folks. And I don't know how much folks on the call maybe work with mandated folks, but in different circumstances, we have people who are not engaged in treatment, or who are actually resistant to being there. And how has that played out as a peer, and kind of like trying to get people engaged or get people on board, not just with their clinician, which you alluded to, but just in general with like goals and progress, and kind of making it meaningful for them?
I mean, it's hard working with people who are forced into treatment, obviously, you know, and 95% of them, well, maybe more than that, you know, they don't want to be there. Like they're at that last level of like, hey, we've tried everything else, you know, everything else has failed. So we're literally like court ordering you to be locked in this facility and forcing treatment on you, which is, I don't know, you know, I have a lot of my own opinions about that just as a person in recovery myself, you know, because I think there are things that you can do, but it's difficult. Like, you know, there has to be somewhat of that internal motivation for someone to want to change. And without that, you are really kind of limited in what you can do. So I don't know, you know, it could be really difficult just as a person in recovery myself too, like a lot of the negativity around sobriety, where it's very different than being in a typical like recovery community where people are celebrating their sobriety and their recovery, you know, and so just trying to, yeah, I don't know, maintain that balance of self-care is super important when working in this field. But I don't know, you know, I think in that capacity where people are very resistant, I think is especially important for them to see people who have made it out, you know, because a lot of them never have, you know, they've never been exposed to anyone actively and successfully in recovery. So I think that is especially important. Yeah. You know, even if they're not necessarily ready yet to take that step themselves, just to see like that, hey, this is actually a thing that people do, you know.
Yeah, thanks so much. I mean, like Piper said, there's clearly no easy answers, but I can imagine that just like by being there and by example, you're kind of like one step closer to kind of invite them into a different experience if that's something that they want for themselves. So thank you for sharing.
I want to thank Emma so much. I know this was a brand new experience, and I appreciate you taking a chance on us and allowing us to hear a little of your experience. This has been very helpful, and we really truly appreciate it. So thank you. And we're going to do a case presentation. You are more than welcome to stay, but we absolutely realize if you have other things on your plate and you need to take off, that is absolutely okay as well. So thank you very much.
Thank you, Emma.
Yeah, thank all of you guys too for inviting me.
Yeah, this was awesome. I'm super glad you decided to do it, and we'll be in touch. So I know you're on vacation in Florida, so you should go do your thing.
All right. Well, thank you all again.